This is Outbreak News This Week, brought to you by the Global Dispatch Incorporated. Outbreak News This Week is your source for all the news about worms and germs. And now, your host, microbiologist and editor of OutbreakNewsToday.com. Here's Robert Harriman.
Hey everybody, this is Robert, and welcome to Outbreak News This Week. Well, more than 1 billion people, approximately 1/6 of the world's population, suffer from one or more neglected tropical diseases, or NTDs. Now, the NTDs are a group of infectious diseases that are the source of tremendous suffering because of their disfiguring and debilitating and sometimes deadly impact. Now, they're called neglected because they have been largely wiped out in more developed parts of the world and persist only in the poorest, most marginalized communities and conflict areas. Now, social stigma is a major consequence of NTDs. In addition to causing physical and emotional suffering, these devastating diseases hamper a person's ability to work. They keep children out of school, and they prevent families in these communities from thriving. There's quite a few NTDs on the World Health Organization list, and they're primarily parasitic. There's some bacterial, and then there's rabies, which of course is viral. So you're talking about Buruli ulcer and schistosomiasis, guinea worm disease, African sleeping sickness, yaws, trachoma, bacterial eye infection, onchocerciasis, leprosy, and several others. So it's a major issue in a lot of parts of the world. On today's show, I'm going to spend a little time with some interviews on a couple of these very important NTDs. In the first half, I'm going to play an interview that I had with Dr. Patricia Dorn on Chagas disease, right? The parasitic disease that you get from the kissing bug. And then in the second half, I'm going to look at Schistosomiasis, right? That's another parasitic disease. It's often considered the second most important infectious disease, outside of malaria. And I'm going to play an old interview with parasitologist Rosemary Drisdelle, and we'll check those out, and maybe we'll talk about a few other things if time permits. And okay, first we'll talk about Chagas disease. Joining me now is Patricia Dorn, PhD. Dr. Dorn is a Hutchinson Distinguished Professor of Biological Sciences at Loyola University New Orleans. Dr. Dorn, welcome to the show, ma'am.
Thank you very much, Robert. I'm happy to be here.
Yes, ma'am. I'm very happy to have you here. And I saw the news release from Loyola, and it caught my attention, and your class trip was very interesting and actually made me a little jealous because I didn't have any opportunity like that when I was an undergrad.
Yeah, at Loyola we believe by learning by doing.
Yeah, it's fantastic stuff.
The field is the way to learn.
Yeah. But before we get into that, I want to give my audience a good overview of Chagas disease so they have a good understanding of what this parasitic disease is all about. So, Dr. Dorn, what is Chagas disease?
So Chagas is named for Carlos Chagas, a Brazilian more than 100 years ago. He described the parasite. As you mentioned, it's a parasitic disease. He also described these kissing bugs that transmit the disease, so they carry the parasite. And he also described reservoir species, so many animals that carry the parasite. So it's actually a leading cause of heart disease in Latin America.
And you mentioned Latin America. Are there other parts of the world where Chagas is found, and how prevalent is it in Latin America?
It's actually the most serious parasitic disease in Latin America. More than 6 million people are carrying the parasite. It's endemic to Latin America, but of course, we're a global world now, and we all move around quite a lot. So there's a very rough estimate of maybe it's 300,000 people in the U.S. carry the parasite, and maybe it's 100,000 in Europe, Japan, Australia, etc.
Now, you mentioned a vector called the kissing bug, and this is how people and animals would get infected with the parasite, and the parasite's name is Trypanosoma cruzi.
Exactly. So it's a little protozoa and a microscopic single-celled trypanosome. And yeah, it's carried by what we call kissing bugs. Isn't that a nice name?
Yeah. Sounds very nice.
Yeah. So most people, in fact, about 80% of the people will get the parasite through this kissing bug, and they're stealth feeders. They actually hide during the day in the cracks and crevices, usually in like adobe huts, substandard house. And they come out at night and they feed. We call them kissing bugs because what's uncovered at night is your face, right?
Mm-hmm.
So they could feed on your face, but they actually can feed anywhere on the body. And we also call them very bad-mannered bugs because unlike a malaria parasite, which is injected into you by a mosquito, these kissing bugs actually poop while they're feeding.
Nice.
So they're taking so much blood that they have to excrete some liquid to keep feeding on so much blood. So they sneak out at night, you're asleep, they crawl down the wall of the adobe hut, crawl under your skin, and take the blood meal and poop at the same time. Parasites in the poop, and of course you're asleep, so you scratch it, and the parasite gets into the bite wound or your eyes or nose or mouth and gets into your bloodstream and then goes off to its target tissue.
Now, that's not the only way we can contract it, though, right? I mean, I've read reports of people in Venezuela or Brazil getting it from the berries that they may have eaten.
Exactly. So the most common way is through this kissing bug insect vector. But very sadly, mothers can pass it to their babies. Congenital infection, about between 1 and 12% of the time an infected mom will pass it to her baby. The food or drink contamination. So you remember these bugs like to hide in cracks. And if they're in that sugar cane or with the juice and you press the sugar cane to make fresh sugar cane juice or the berries and there's bug poop in there with live parasites and you drink it, you absolutely, and there's been these microepidemics in Brazil, Venezuela, and other places. Also, blood and organ transplantation. And just in 2007, the U.S. started screening the blood supply because there were less than a dozen cases of blood and organ transplant transmission of Chagas. And also, we always have to be careful because laboratory accidents actually are a concern if you stick yourself with a needle with the parasite. So the main ones, kissing bugs, but also congenital or mother to baby, and contaminated food and drink and blood and solid organ transplants.
Now, how about the signs and symptoms? I mean, is there an acute disease and a chronic disease? And how does this work, and what organs are really affected?
Right. So when we're first infected, we may have a bad headache, even for a couple weeks. We may have a swollen eye, one swollen eye called Romagn's sign, if that's where the parasite feces went in, or what's called a shigoma, which is a lump on the skin where the parasite entered. But for most people, and if you think most people that are at risk in Latin America in very rural, poor areas, they have sort of flu-like symptoms not infrequently from all kinds of infections. And so most people have no idea they've become infected. And this acute phase lasts, the few weeks to a couple months, and then the parasite goes into the tissues. So it especially likes heart muscle. That's the main organ that's affected. And then there's absolutely no symptoms. And the person may live 10, 20, 30 years and die suddenly of heart disease and never know that they were infected. So the main symptoms for the acute phase are that one swollen eye, maybe a headache, fever, but very nondescript. But the chronic symptoms are heart disease, and then also in South America we see a mega syndrome where the nerves are damaged, and actually your body overgrows the organs like your esophagus or your intestines. So your intestines can be as big around as your upper thigh.
Right.
And you can imagine the horrible digestive problems these people have. But that's less frequent than heart disease. Heart disease is the main symptom.
Sure. Now how is Chagas treated?
So not very well, unfortunately. Presently, we have 2 drugs available, and they need to be taken for 1 to 3 months, and they have very nasty side effects. And so some people just can't even tolerate the drugs. There's some new ones in the pipeline. The Drugs for Neglected Tropical Diseases, the NDI, is working very hard on trying to get some new drugs available. In the U.S., FDA has no approved drugs for Chagas. So you need to go to the CDC, and there are these 2 drugs available through an investigational protocol.
And so since the treatment options are not that great, preventive measures are probably key.
Absolutely. So keeping humans away from those kissing bugs is really preeminent in terms of avoiding transmission and preventing this disease in the first place. And that's really been the focus of our research.
All right. Now, you mentioned a rather large number concerning Chagas here in the U.S. I've had other parasitologists on the show telling me the same thing. And I've actually had somebody from the San Antonio Humane Society several years ago discussing, a rash of dogs they were seeing with Chagas. Are we seeing this big number of Chagas from migration of people, or is a lot of the stuff localized?
Right. So a very rough estimate, because of course it depends on knowing how many people are coming from endemic countries, as well as how many of those are coming infected. And so a very rough number is 300,000 immigrants from Latin American countries are in the U.S., and we really need to be concerned about identifying and screening, especially pregnant women, so that they're not passing it on to their babies. But in fact, locally acquiring the parasite is very rare in the U.S. It's less than a couple dozen cases of locally acquired Chagas disease have been documented in the U.S. And remember now, this is after screening tens of millions of units of blood. So it's probably still not very frequent that people are contracting the disease from the kissing bugs in the U.S. Although the kissing bugs are here, and we've shown in our lab and others as well, the bugs are infected. But you're right about the dogs. And we did some studies here in Louisiana. In fact, I worked with Homeland Security. They have a large kennel in Texas, and many of the dogs were dying of Chagas. And we think the dogs and other animals eat the bugs, and they get infected with the parasite that way. And it is a very serious veterinary problem, and none of the drugs are available currently to treat the dogs.
All right. Well, let's switch gears to the trip to Guatemala. Can you tell my audience, what was the purpose of this, and what activities did the students get involved in?
So I've been working in research, just this fabulous collaboration for the last 21 years with investigators in Guatemala, looking at how we can prevent transmission. And my collaborator there has developed this eco-health approach. So it's community-based, where the villagers are involved and make home improvements that make their houses refractory or make the bugs not live in the houses with them. It's environmentally friendly. We worked for a couple of years with architects and engineers, developing local materials for very low cost, so $50 a house, and the villagers do the work. And, again, we can't afford cement, but there's lots of volcanic ash, and we've developed local materials to plaster the walls and to, quote-unquote, I'm air quoting, the cement, because it's cement made with volcanic ash and sand, etc. And this has made it possible to interrupt transmission of Chagas in Central America. Well, normally this is something the villages would do for themselves, and we teach them. But of course, there's elderly people or disabled people or people that can't make their own home improvements. So my students are learning about parasitology, and I thought, what better way to take them to the field, see what conditions put people at risk for contracting Chagas and other parasitic diseases. And what we did is improve the house of an elderly widow a 75-year-old woman named Doña Maura, and the students went and they learned the eco-health method side by side with the villagers and improved Doña Maura's house so she doesn't have to worry anymore about Chagas. We've also seen that there's less malaria, and also you don't get the worm infections that come from having the dirt floor. Mm-hmm. So I think it was a pretty powerful way to learn parasitology and interact with the community. And of course, as a Jesuit school, Loyola University New Orleans is all about being women and men for others and service learning. So this was our service learning project.
Fantastic. Now, was part of that getting rid of the thatch hutches, the thatch roofs and all that?
So in this village where we're working, they pretty much they've changed over to those metallic roofs. Uh-huh. And interestingly, the main species that's there presently lives in the adobe walls. The one that was introduced, Rodnius, is the species that lived in the thatch roof. We've mostly eradicated by spraying. But spraying doesn't work for this species because it lives in the forest as well. So you spray and you come back 3 months later and it's back in the house. So that's why we have to make these long-term improvements with plastering the walls and cementing the floors, and then the bugs stay in the forest and don't come back into the homes.
How many students joined you?
So 6 students were able to come with me, and I was really proud of Loyola supported them in paying nearly all of their airfare. And then the 4 students who couldn't come did complementary projects. So they actually worked with Loyola design students and made educational materials that we then brought and handed out in the village.
Oh, that's great. So, I mean, the people of the particular village you're at, were most of them familiar with Chagas or not?
Right. So we've been working there, as I mentioned, for some time and working on the eco-health method. And we've shown through several scientific studies that it very effectively interrupts transmission. So we've been able to get the interest of other partners, including World Vision, and also a group of elementary school kids from New York that contacted me, Kids for World Health. And with the support of these other partners as well, we've been able to improve over 7,000 homes in Central America, and now we're expanding to extend this across Central America and hoping to interrupt transmission of Chagas across Central America with this eco-health approach.
Now, so how serious is the problem in Central America as opposed to South America?
It's extremely serious, especially Guatemala, El Salvador, and Honduras. We're still seeing acute cases. So what we do is test the blood of school children to find out are people still getting infected, or is the people that show positive for T. cruzi, the parasite, from when Rodnius was there, that was a very efficient vector, or because they contracted the disease earlier. And we're seeing in those 3 countries that there still is active transmission. So it's a very serious. And again, it's throughout Latin America, it's more serious than all the other parasitic diseases together, including malaria, onchocerciasis, leishmaniasis, all of them together.
Mm-hmm. Now, you collaborate with other researchers around the country and in Guatemala. I believe the website, correct me if I'm wrong, it's chagasecohealth.com.
Right. Chagasecohealth.com is the collaboration mostly with Central America and some in Mexico, yes.
Yeah. So what kind of projects are you guys working on?
So we have a 5-year NSF grant to actually do a mathematical model to model transmission risk, so to take in all the factors and really be able to focus on how to best interrupt transmission. And it's pretty exciting because we're using the new genomics and bioinformatics tools, and we collect the kissing bugs from the houses or the chicken coops or even in the forest, and you can just take the DNA from the bug abdomen, and you've geolocated that bug, so you know exactly where that bug came from. You know how many people live in that house, the quality of that, the walls and the roof in that house, how many dogs are there, what the people do for a living. And then you can look from the DNA from the abdomen of the bug, the genetics of the bug, the genetics of the parasite, because there's actually 6 different strains of the parasite. Interestingly, we can also tell what the bug's been feeding on And now we have this very rich data set that's all the biology and also all the sociology. And we're working with engineers that are doing some mathematical modeling to be able to put all that data together and really focus our efforts on how best to interrupt transmission.
Oh, fascinating. Very fascinating.
So that's one thing. Can I talk a minute about what we're doing in the U.S.?
Absolutely.
So I work with, so Carlota Monroy is my main collaborator in Guatemala. She's the first woman ever to win the National Science Award in Guatemala. And in the U.S., I work with Dr. Steve Klotz, who until recently was chief of infectious diseases in the med school in Tucson, and Dr. Justin Schmidt, who's quite famous, in fact was interviewed 243 times last year for his Sting of the Wild book. He let all these critters sting and bite him, and he talks about, you might want to talk with him about how it felt. So we've been looking in Bisbee, Arizona, and especially Zacatecas Canyon, because one of the reasons that people in the States don't get Chagas so frequently because of the kissing bugs is that we live in houses that are with air conditioning, and so we don't live with the bugs. But in Bisbee, we're finding that the bugs live in the houses and complete their life cycles in the houses. So I think we're going to go this summer and test the population and see if they're getting infected, and also do some environmental surveys of, what puts people at risk of having the bugs in their houses. So it looks like, although bugs don't normally colonize, the kissing bugs don't normally colonize houses in the U.S., in Bisbee they are. So we're following up on that. So that's another interesting project we have going. We're also working here in New Orleans. My lab, along with some folks at Tulane, identified the first local transmission in Louisiana, here in New Orleans. And we've done some studies about what the bugs are feeding on here. And it's been pretty interesting. The main blood source for the bugs is frogs.
No kidding.
Which was kind of a surprise.
Yeah.
There's lots of frogs here. The second most common blood source for the bugs here is humans. So it kind of overturned the dogma that humans and bugs don't interact in the States. We've seen that also in Arizona, where we've looked at blood sources. In fact, a lot of the bugs are feeding on humans. They're just not very efficient at transmitting the parasite. We kind of say that they're better mannered, so they seem to take their blood meal and then leave the host and go poop later. Maybe that explains why they don't transmit as well.
Right. Well, really interesting stuff. And I encourage the audience, if they want to learn more, check out www.chagasecohealth.com. Thank you, Dr. Patricia Dorn, for your time and expertise. And, ma'am, keep up the good work.
Thanks. Thank you very much for the opportunity.
You bet. Take care.
Bye-bye.
All right. I hope you enjoyed that interview with Dr. Dorn. And before we get to the hard break, let me turn to the website, outbreaknewstoday.com. And one of the headlines today is this report of 2 teens that died of tetanus in Kenya after a circumcision. And apparently the circumcisions were performed by, quote, close quote, traditional circumciser, which has gone missing. So, there's very, very big concerns with circumcisions done in certain parts of the world because maybe not clean instruments, clean environment. And the World Health Organization says, to reduce the risk of tetanus associated with circumcision, you got to really deal with the poor hygienic conditions and practices and vaccination. So clean care, you got to enhance attention to standard protocols for skin prep and cleanliness, both at the facility it's being done at and the individuals who are undergoing the circumcision procedure. And of course, tetanus toxoid containing vaccine, you got to ensure that all the patients are adequately protected against tetanus by vaccination prior to circumcision. So, okay. And after the break, we're going to go ahead and take a look at another neglected tropical disease, schistosomiasis.
Welcome back to Outbreak News This Week, your source for all the news about worms and germs. Here's your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Well, welcome back to the program, and welcome back to this Eve before Christmas Eve show, featuring a couple of major important parasitic diseases, important neglected tropical diseases. We talked about Chagas disease in the first half, and in the second half, we're going to take a look at schistosomiasis. And again, I want to always encourage you to check out the website OutbreakNewsToday.com, OutbreakNewsToday.com, for all your news about worms and germs. And at the end of the show, I'm going to give you a little hint of what's going to be coming up in the new year. So, but first, schistosomiasis. Joining me to discuss this neglected tropical disease is Rosemary Drisdelle. Rosemary is a parasitology teacher and author of the book, Parasites, Tales of Humanity's Most Unwelcome Guests. Hi, Rosemary. Welcome back to the show.
Hi there. A pleasure to be here, as always.
Good. Now, parasites of the genus Schistosoma are from the class Trematoda. And we've discussed a number of trematodes over time on this podcast. However, it does differ from some of the other flukes in a couple of important ways. Rosemary, how are schistosomes unique among the trematodes that infect humans?
As you said, there are a couple of ways that they're unique and quite different. For one thing, there are male and female worms. Most of the trematodes are hermaphrodites, so they have both male and female characteristics. But with the schistosomes, we actually have males and females. Another thing is that rather than living in the intestine or the liver, they live in the blood. And they only have one intermediate host. Most of the flukes have at least two, the ones that infect humans. The other thing is that they're very small. Some of the liver flukes are quite small, but the schistosomes have them beat. They're actually so small that even in a pair of male and female worms, they could curl up on the end of your little finger. They're very tiny.
Now, schistosomiasis is often referred to as bilharzia. Where does this name come from?
They're actually named after the person who discovered them. Theodore Bilhars, back in 1852, discovered the worms that cause schistosomiasis around the bladder, the ones that cause the urinary type. So it was named after him initially.
Okay, well, there are 5 schistosomes that caused human schistosomiasis. Rosemary, what are they? Where are they found? And follow up with that with how many countries today still see schistosomiasis?
Yeah, there are 5 that we sort of refer to regularly. 3 of them are the really big ones. And there are actually also a couple of other species that we don't refer to quite as often because they just occur in very small geographical areas. Schistosoma mansoni is found in South America, some of the northern countries in South America, the Caribbean, and in Africa and the Middle East. And then we have Schistosoma japonicum, which occurs in China, Indonesia, and the Philippines, as its name suggests. Schistosoma hematobium is known in Africa and the Middle East, also the island of Madagascar, and quite recently introduced to Corsica. And then we have Schistosoma intercalatum, which looks a lot like hematobium, but is a little bit different. That's found in some areas of Africa. And Schistosoma mekongi occurs, as you might guess, along the Mekong River, so in Kampuchea and Laos.
So how many countries today still see human schistosomiasis?
Yeah, the World Health Organization lists about 70 countries that still experience it. And actually, it's still very common. As you said, over 2 million people infected and about 206 million people at risk.
Now, the life cycle. I love listening to you talk about the life cycles of these parasites. And the life cycle of the schistosomes is pretty complicated, isn't it?
It is, and it's fascinating. If we start with the egg itself, that would be passed from an infected human, either in stool or in urine. If that egg finds itself in fresh water, then it will hatch. There's a little creature inside the egg called a myristidium, which is very active, which swims about very actively in fresh water. They're quite fascinating to watch. And what they're looking for is a specific species of snail. It's not just one species of snail, but it is fussy about which species it can go through its asexual stage of development in. So if it finds the right type of snail, it will invade the snail's body and go through, as I said, an asexual stage of multiplication, eventually leaving the snail, and then it hangs around in the water, and it's like a little balloon in the water, and it rises up to the surface and then slowly sinks down towards the bottom, moving back and forth like that, hoping that an appropriate human host is going to come along. And if one does, they actually will latch onto the skin. At this stage, they're called a cercariae, and they will penetrate the skin, disappearing through the surface of the skin in about 10 to 30 seconds. They will enter the bloodstream and travel to the heart, and then through the lungs and into the systemic circulation. Their goal at this time is the liver. They spend a little bit of time maturing in the liver and pairing up as male and female worms. And from there, they travel to whichever part of the body their specific species is inclined to spend their lives around. So some of them go to the tiny capillaries in the blood vessels around the bladder, and some will head for the intestine. And there they remain as male and female pairs, with the male actually wrapped around the female like a little blanket, and she basically just spends her life producing eggs. So those eggs are released in the tiny capillaries there, and most of them, particularly in Mansoni and Hematobium, they have a wicked-looking sort of spine on the egg, which helps to lodge them in place. And they will eventually break through the wall of the capillary into the surrounding tissue, and with a little bit of help from our immune system, they will work their way towards either the lumen of the bladder or the intestine. And once there, of course, then they can be passed to the outside world, and the whole thing starts all over again.
And so people do contract this by contact with contaminated water.
That's right, contaminated fresh water. Yes.
Fresh water, right.
Yeah.
And if you're in an area where schistosoma is endemic, it's really almost impossible to tell if that water is contaminated.
That's right. The only way you might know, and especially if you were exposed to it for the second time, you might feel a kind of prickling sensation as the cercariae are penetrating your skin. But no, you probably would have no idea until that happened, that you were being exposed.
Now, schistosomiasis is sometimes considered a man-made disease. What is meant by that?
Indeed, it's one of those parasites that we have catapulted from probably being relatively rare to being extremely common as it is today. And we've done that by creating the perfect environment for the life cycle to complete itself. So water resource projects, dams, create large lakes, as you know, with usually a lot of vegetation growing around the shores of the lakes. This creates ideal snail habitat, and it also creates ideal habitat for people. So we have people moving to the shores of these large lakes where they can obtain water whenever they need it. They can go fishing. They can even, grow some of those water plants, and the children play in the water, and laundry gets done in the water. So there's a lot of human contact with the water, and that tends to really ramp up the amount of schistosomiasis in the area.
Now, schistosomiasis is an acute or a chronic disease, but it's not a single disease. It's kind of a disease complex.
That's right.
Rosemary, I want to focus on the big three schistosomes, Schistosoma mansoni, Hematobium, and Japonicum. And for each species, can you discuss the pathology and the morphology of the adult and egg, And let's go ahead and start with Schistosoma mansoni.
Yeah, so I mentioned that mansoni is one of the ones where the egg has a really wicked-looking spine, and this is the chief characteristic by which we can identify that species of schistosome. We find the eggs in the stool. So for all of them, basically the initial infection would be characterized by chills and fever, perhaps tiredness, headache, kind of a severe flu-like illness with fatigue and perhaps some swollen lymph nodes and maybe some gastrointestinal symptoms. But that does fade away after a while. So for mansoni, actually for all of them, the initial infection would be much the same. For hematobium, mansoni, I should mention, lives around the intestine, so we find the eggs of Schistosoma mansoni in the stool. That's also true of japonicum, Schistosoma japonicum. Hematobium's a little different. We find the eggs of that species in the urine. And that one, hematobium, is associated with bladder cancer, and that's probably because of the constant sort of chronic irritation of the bladder wall due to those eggs moving through the tissues. So with chronic mansoni, you're going to see perhaps some bloody diarrhea, abdominal pain, and lethargy, which goes on for, basically forever, because people don't really get over it. These worms can live for 20 to 30 years. And similarly with hematobium, we see bloody urine. And people in places where these parasites are endemic, they know the symptoms and the signs, and they consider it quite normal. Often they don't place a whole lot of importance on seeing the bloody diarrhea or the bloody urine.
Now, obviously these produce a lot of eggs, and the pathology is directly related to the number of eggs too, I imagine, right?
Yes. As time goes on, the eggs that are passing through the tissues tend to get kind of enveloped in tissue that the body produces, and they don't get passed in the urine or the stool in quite such large numbers, so it can be hard to find them. But the other thing about these eggs is that some of them, of course, get swept away in the bloodstream. And so they can build up in parts of the body, particularly in the liver, where the bloodstream goes, and cause a lot of liver damage, cirrhosis of the liver. And you see pictures of people with chronic schistosomiasis with very enlarged abdomens because they've got a buildup of fluid in their peritoneal cavity. And they tend to be, as I mentioned, very, very tired and lethargic. And children don't grow. Their growth can be quite retarded, so there can be quite small stature if they've had schistosomiasis for their whole lives.
Now, as somebody who's worked in a parasitology lab, these characteristic eggs are very hard to miss. It's a very easy diagnosis.
That's right. The only thing you have to really watch out for is that if they roll over, especially with mansoni, if they roll over on your microscopic preparation so that the spine is underneath, sometimes you don't see it. And so you might miss it that way or think that it was something else. But fortunately, in a wet mount, you can tap it with a pencil and get things to roll over. So that's a little trick we use a lot.
Now, are there other methods, serological or otherwise, for identifying the schistosomes?
There are, but unfortunately, there's nothing that works really, really well. If we look for antibodies, those take a fairly lengthy amount of time to appear in the bloodstream, so you can't always identify an acute infection accurately. And then if we look for the antigen, if we look for the parasite itself, those tests tend to be somewhat unreliable. You miss a lot of positives that way. So there's nothing that really is reliable all the time. For travelers, probably the best way to look for a schistosome infection is to check for the antibodies and just wait a bit of time and see if those antibodies develop. But if we're checking people in endemic areas where there will be a high level of infection, then usually we look for the eggs in the stool.
Now, a lot of times with the schistosoma infections, people may not realize they have it for decades after. I remember hearing stories of people come back from World War II and finding out as an elderly man or even post-mortem that they had the infection.
That's right. As I said, the worms can live for decades, so you can have it for a very long time and not realize.
Yeah. Fortunately, treatment is pretty well established for schistosomiasis.
Yes, praziquantel is the drug of choice, and it's quite effective. But of course, the earlier the better, because once you start getting that tissue damage and the cirrhosis of the liver and eggs building up in various parts of the body, it can be too late to reverse that damage.
Mm-hmm. Now, concerning prevention and control, I want to talk about the individual traveler to an endemic country. So if me or you are traveling to parts of Africa or South America, what should we be concerned of?
Well, you definitely want to avoid contact with any fresh water that was suspect, that you thought might be contaminated. So that would include drinking water. You could boil that, or you could filter it, or perhaps let it stand for about 24 hours before consuming it, but you certainly wouldn't want to dip it out of a pond or even take it from a tap if you thought the water came from a pond that could be contaminated. You wouldn't want to bathe in it either without heating it first, so to about 50 degrees centigrade or 122 Fahrenheit would be, for 5 minutes, would heat your bath water enough. Chlorinated swimming pools would be okay as long as you were confident that the chlorination was at a sufficient level, but that would be your key to avoid contact of your skin with water that could have those cercariae in it.
Mm-hmm. Now, is there a vaccine for this parasite? And if not, is there anything out there in the pipeline?
There isn't a vaccine so far. There is a lot of research. A lot of people are doing research on trying to develop a vaccine, but at this point in time, no, there's nothing.
Now we'll turn to more large-scale prevention and control measures. What are they doing out there for these, hyper-endemic areas?
Yeah, when control is really, it needs to take a multi-pronged approach. So mass treatment of people, sometimes everybody in a community needs to be treated. Sometimes just people, school children in particular, because we know they love to play in water, right? And adults who are at risk. So those would be people who have common contact with the water. Fishers, women perhaps who gather water or do laundry, pregnant women, that kind of group. If they were picking different groups that would be at higher risk, those would be the ones they would choose. So mass treatment of those people with praziquantel, and then providing clean drinking water is important. Improving the sanitation, because of course what you really need to do is prevent eggs from entering the fresh water in the first place. And then education of the population and snail control. Although snail control, it's hard to kill every snail. They do tend to come back. So it can be helpful, but it's not going to work in and of itself.
And I would even think education would be a little bit difficult because you got populations that have been defecating and urinating in the water for
That's right.
generations.
Right. And often people who live in these endemic areas don't really take the infection all that seriously. They don't take it as seriously as perhaps we would.
Yeah. All right. And there has to be many fascinating stories, historical or otherwise, about the schistosomes. Rosemary, what do you have for us today?
As you say, there are lots of stories and hard to choose one, but I think perhaps my favorite is the theory of what actually happened in Jericho. We all know the story of Joshua and the Battle of Jericho, the biblical Old Testament story, which has Joshua arriving with the Hebrews at the village of Jericho and walking around its massive walls a couple of times, and the walls all came tumbling down. But the version of the story that involves schistosomes, and of course this is not proven, but there is some evidence that there could be some truth to it, suggests that the people of Jericho they all had chronic schistosomiasis. We know that one of the snail hosts was there because remains of that snail have been found in the rubble of Jericho. And we know that they were trading with people who came from areas where the parasite was well established. So it's certainly believable that Schistosoma hematobium could have been introduced to the spring, which supplied all the water for Jericho. It's in a very arid place, and their only source of fresh water, really, without having to walk a very long way, was that spring. So the people had contact with the spring water all the time, and they used it for everything from bathing to irrigating their crops, and anything they needed water for, they would go to the spring. So once that spring got contaminated, then every person in Jericho would have been exposed to the water just about every day of their lives. So the thought is that by the time Joshua arrived there with his army already, the people of Jericho were very sick and lethargic, and they were not doing a good job of maintaining their defensive walls around the village. Things were ready to topple already, so it was an easy task for Joshua and his troops to take out the village. And then the story tells us that Joshua cursed the village and that nobody lived there for hundreds of years. Mm-hmm. And so though it's populated today, it was uninhabited for long enough that the parasite would have died out with any hosts, there to help it finish its life cycle. And also there were some very dry periods in that time which might have wiped out the snail as well. So it's a plausible story and quite fascinating, I think.
Oh, it really is. All right. Well, again, thank you, Rosemary Drisdelle, for your time and expertise and your fascinating stories. I appreciate it.
My pleasure, as always.
Thank you. All right. Well, I hope you enjoyed that discussion on the parasitic disease, schistosomiasis. And again, check out the website, outbreaknewstoday.com. And as you know, we do a podcast. It's called Outbreak News Interviews, and that can be found on the website. It can also be found on Apple Podcasts, Stitcher Radio, and Spotify. And had a very good, the most recent podcast that I did was really, really good one. I was joined with Dr. Ying Zhang from Johns Hopkins, and he's the one that did that recent study on Lyme disease where he tested a group of essential oils to determine their effectiveness against the persistent Lyme bacteria. So really good interview. I encourage you to check that one out at the website, at Apple Podcast, at Stitcher Radio, or Spotify. And also after the new year, got some plans to take on a new project, and I'm going to be calling that Outbreak News TV. And essentially, it's going to be an internet TV show, interview-based, and it'll be on YouTube. And I'm hoping to get some really, really good guests to look at some really, really good topics. And you'll be able to find it. The YouTube page already exists. It's Outbreak News TV. And right now, basically, I've been putting up podcasts there. So it's just been audio. But I want to go ahead and add some video and some good interviews with some. The Rolodex is pretty big, and I'm hoping to get some really good interviews coming up on that program. Let's take a look at the website before we go ahead and call it a day. And got more African swine fever over in China, and we discovered this week that it has spread to the 23rd province, Guangdong province in southern China. So it's really spreading through lots of areas of China, particularly in the south. And I even saw that Taiwan is putting up all kinds of warnings now for obvious reasons for their concern of the virus spreading to pigs in their country. And, African swine fever doesn't pose any direct health threat to humans, but in its most virulent strain, it's 100% fatal in infected pigs. So it's a huge problem for the swine industry, particularly in a place like China where they produce half of the world's pigs. So, yeah, really big deal. Okay, let me go ahead and wrap this up and have a very Merry Christmas, and I will see you next week on Outbreak News This Week. Good day. and God bless.
Thank you for listening to Outbreak News This Week with Robert Harriman. If you missed any part of today's program, you can listen to the podcast anytime on our website, outbreaknewstoday.com. Make sure to join us here next week for Outbreak News This Week with Robert Harriman.